Dr. Senthil, G. Senthil. So he is going to talk on the dressings and footwear in neuropathy and ulcer. Stage-based prescription, a visual guide with interactive participation.
Good afternoon, everybody. I would like to make 10 minutes PowerPoint presentation and 10 minutes demonstration of the dressing materials and offloading devices, and 5 minutes for audience interaction. To start with, before starting my subject, I'd like to declare, I may mention some of the brands, pharmaceutical brands. This is not to promote any other pharmaceutical company. This is only for educational purpose. And to be frank, I am also not a branded person like Dr. Andrew Bolton. So this is only a presentation, and it's a very important topic. So after diagnosing neuropathy, we have to give a proper offloading footwear. And after doing a callus excision and wound cleaning, we need to do the proper dressing. So it's a really important subject. Either it's a grade 1 superficial ulceration or grade 2, grade 3 ulceration, dressing holds very important role in diabetic foot management. Starting with saline gauze dressing, those days it was a gold standard, not anymore, now it's old standard because, so once you put a saline gauze, within hour it become dry. So removal of the saline, the dry gauze will be difficult. Patient may have pain if they are not neuropathic, and it may produce bleeding, and cotton particles might get stuck into the wound, and we need a bulky dressing, and repeated dressing has to be done. So then came the 3-layer dressing. Initial wound contact layer will be a non-adherent dressing, then absorptive gauze layer, then cotton padding. 3-layer dressing was okay, but it was so bulky, and usually patient won't wear their offloading footwear because of the bulky dressing. Usually they won't fit into the footwear. So most of the times they won't use the footwear, and again, it is not the best way to do dressing. Then came that active dressing. So dressing should not be a simple cover for the wound, so it should actively participate in healing, like a granulation tissue formation, and it should inhibit the bacteria. It should have a relatively moist environment throughout the period of healing. So we have a lot of recent materials like hydrogels, hydrofiber, foams, alginate, and silver containing materials, colloidal materials or fibers. So dressing may be broadly divided into primary and secondary. Primary dressing means the dressing which comes in contact with the wound. That's called primary dressing. And the dressing which covers the wound, which covers the primary dressing, that's called secondary dressing. Here you can see the grade 1 ulceration on the left forefoot with the callus excised wounds. And here definitely we need a dressing, but no need for the bulky dressing. So here we are covered with transparent, thin hydrocolloid dressing. So it's a waterproof dressing. It allows only water vapor, and it won't allow the water or bacteria inside the wound. So it's a protective dressing. It's a semi-occlusive dressing. You can leave the dressing for 3 to 4 days. Patient easily can fit into their footwear, as you can see it. So as I told you earlier, here you can see that grade 1 ulceration secondary to the scald injury, and callus also there. So after callus excision also, if the dermis is exposed to cover the dermal wound, you can use this hydrocolloid dressing. Even for the grade 1 ulcer, we can use the hydrocolloid dressing. Easy to apply, it's self-adherent, no need for extra plasters, and it's a waterproof dressing. Patient even can have bath. So that's the advantage of this dressing. It's cheap, easily available everywhere. Coming to the hydrofibers, it's a sterile carboxymethyl cellulose fiber, and it's like a fabric. You can fold and you can fit into the wound surface. It conforms to the wound surface, so it gives a proper contact, and it interacts with the gel, interacts with the wound moisture, and it forms a gel that maintains the moisture of the wound. So as we all know, wounds should be maintained moist. So otherwise the cell dehydration, cell death will be there. So moisture environment will help in autolytic debris, granulation tissue formation and better epithelialization. The same hydrofiber is available with the silver impregnated materials also. So here this is not like normal silver ointments what we have. So normally that ointment will release the maximum amount of silver into the wound at the moment and it won't be long lasting. Here there will be a slow release of nanocrystalline silver particles at the rate of 70 to 100 parts per million. And it's very much effective against MRSA and vancomycin resistant enterococci. So far, not many of the organisms seem to be resistant for this silver. Coming to the foam dressing, and here the foam is less bulky and it serves the 3-layer purpose. Most of our dressings are non-adherent dressings, so it won't adhere to the wound. So we can easily remove the dressing without producing any bleeding or pain. And another advantage, minimum we can leave it for 3 to 5 days. Minimum 3 days we can leave. If the wound is exudating more, we can leave it for 2 to 3 days we can leave. I mean less exudating wound we can leave it for 4-5 days also. It has a 3-layer. It's a polyurethane foam dressing. And as you can see it for the burns and other superficial wounds you can very well use it. So here easily can fit into that footwear. Otherwise, with the cotton padding, bulky dressing, they won't wear the footwear, and usually the plantar ulcers will never heal when the patient walks on the ulcer. Coming to the gel, gels are available as a plain polymer or water-based gel, or it comes with the colloidal silver particles also. It gives a moisture environment. So naturally, wound should be maintained moist for whatever reason. Because once we leave it open, so most of the patients will think leaving the wound open will get dry. But dry means it's a cell desiccation, cell death. It forms a scab. So under the dry scab, there will be a pocket of pus and the infective slough will be there inside. That's anyway not good. So dry wound means it's not a good skin or it's not a healing wound. So we should never allow the wound to get dry. If at all any scab or slough is there, we need to remove it. And whatever the dressing I'm telling, so we have to properly clean. So we have irrigation fluids. So we have to thoroughly cleanse the wound. After that, only we should put the dressing materials in place. So hydrogel serves the purpose of maintaining moist environment for 48 hours. So normally our practice will be application of the ointment, either betadine, povidone iodine or mupirocin ointment. We put a gauze, plaster. So at the time of removal, you will see all the povidone iodine or mupirocin ointment will be stuck into the gauze only. So wound will be dry anyway. So dry wound is a problem for healing, and epithelialization, granulation may not happen. Here the gel, even after removal, you can see the gel still stuck into the wound. So that's the advantage. That's a polymer water-based gel here. Even after 48 hours, once you remove the wound will be fresh, granulating, and the gel will be still stuck into the wound. So that's the difference between this gel and other normal ointments. And so maintaining the moist environment is basically good for healing, and it has its autolytic debris effect. So slough will be pushed away by the granulation, healthy granulation tissue, and it makes the wound relatively less painful, and dressing will be non-adherent. So here you can see a callus. After callus excision, if you find any ulcer, you can do the dressing in a simpler way like this. So at times, the manual debridement is always best. At times, when the slough is stuck very close to the neurovascular bundle or bone and joint, so better we can use this kind of chemical debriding agent, so that with the regular dressing, slowly that slough will get pushed out. And we have a growth hormone ointments also. We have 2 commercially available growth hormone ointments, platelet-derived growth factor and epidermal growth factor. Both can be used. For deeper wounds, when you want more granulation tissue, you can use the platelet-derived growth factor. For superficial ulceration, when you want more epithelialization, you can use the epidermal growth factor. So you have a collagen dressings also. So whatever I'm showing, we have the material, we'll show you in another 10 minutes. So you can use it in your day-to-day practice. So it's, and collagen is very much useful for wound healing, and it's available in sheet form or in a granulation form. In some preparation we have antibiotic components also along with this granulation, along with this granules. Coming to the wonderful form of dressing, it's a vac dressing. So we can use it in the proliferation stage. So once the inflammatory infective stage is over, so we can use this vac dressing to aid the proliferation, so that it helps the hospital, it helps to reduce that hospital stay, and it fastens the healing. It speeds up the healing by mechanical action, and it's a micro action. It increases the mitosis and fibroblast proliferation, mobilization, and it helps in wound healing. And of course, it also reduces the edema. For that, as you can see the first picture, the wound has a slight coat of slough. The vac is applied. Vac has three components. It has a granuform material. That's a dressing material. We just put it on top of the wound, and we put a waterproof offside kind of dressing on top of it, make a small rent, and sensor track tube is attached with the wound, and the other end of the tube is connected to a small suction machine. So normally 125 millimeter of mercury suction pressure is applied by the machine. So it sucks the wound, it sucks the edema, excess edema, exudate, and it brings the edges together, and by mechanical pull, it augments the tissue growth and proliferation, and it also increases mitosis, wound healing, as I told you. With a single sitting, you can see the slough got pushed away and sucked out by that suction, the vac suction. So normally we keep it for 4 to 5 days. Highly exudating wound, we can use it for 4 days. Otherwise, we can keep it for 5 days also. After 2 sittings, you can see nice healthy granulation tissue covering the wound that is easily managed with the skin graft. So we have other variation of vacuum assisted closure machine. It's called Veraflow. Here earlier the dry granuform was applied. Here with the same technique, saline irrigation system is also installed in that. So wound will be irrigated with saline, so moist environment will be maintained there. So that helps in wound healing. So this is fantastic. As a surgeon, actually it aids in very good results. It's a biocomposite. So normally what happens when we deal with the major life-threatening, limb-threatening this kind of wounds. So at times we face problem with critical areas. So foot is not made up of muscle predominantly. It's basically a bone, joint, ligament, fascia, all fibrous structures. We can't have a granulation tissue. To have a proper wound healing, we need a granulation tissue, as we all know. But that's not easily possible in foot infections. So when we deal with the foot and ankle infections, we have to come across bone, joint, bone infection, joint infection. So it's very difficult. In the sense, making a granulation in that area, it's very difficult. But we'll do it by surgical techniques and these kind of biocomposites and vac machines. So once we do the debridement, we can't go too much about the joint and bone. We can do a minimal debridement, and there will be micro infections may be there. Definitely we can deal this kind of wound with a culture-sensitive antibiotic. That antibiotic can be impregnated with a calcium sulfate powder. We can make it into beads. That beads can be installed into the wound. Okay, either it's a cavitating wound, or it's a bone joint involving wound, or like this picture is a surface wound. Any wound can be managed with this kind of calcium sulfate with the antibiotic impregnated beads, antibiotic beads. And here the advantage, earlier we used to have non-absorbable material. We used to put it in the steel wire and place it inside, and after some time we need to remove it. Here, no need of removal. It's hydrophilic and it absorbs 100%, and within a month it will get absorbed, and there won't be any trace, there won't be any nidus for infection. So easily you can put it inside the cavity and you can forget it. So normally what I will show you in some other picture. So when we manage the wounds in a deep areas where the infection control is not possible, in case of tarsal bone involvement and deep bone and joint involvement, where you meddle with the joint and bone, there will be a problem with the bone stability. So in that case, you can do minimal debridement, and you can pack with the culture-sensitive antibiotic impregnated calcium sulfate beads. That takes care of the infection, not 1 or 2 days like other dressings. So it will take care of the wound at least for 1 month. So 1 month it will slowly deliver the antibiotic, and it clears the infection. And you can see the clear granulation, healthy granulation that helps in grafting and wound healing. So this is how the calcium sulfate pellets are prepared. It's so easy. So once you get the culture from the wound, the culture sensitive antibiotic can be mixed with the calcium sulfate powder, and we can prepare the beads, and the beads can be instilled inside that wound. Here, as you can see it, 5th MTP joint septic arthritis was there in spite of surgical debridement, and it was a major limb threatening infection. It was managed well, but the problem is that tarsal bone infection could not be controlled in spite of scooping, nibbling, and debridement, limited debridement, because we can't do too much of debridement in that risky area. So after that, still the pus used to come. So we got use of this product, and really it helped in healing. So wound had closed, and now it's a time for wound closure. So we have a human amniotic membrane dressing also. We can leave that dressing for a period of 1 week, and every week we can change it. It is derived from human placenta, the amniotic membrane. This is also very useful as a dressing material. It's a biological recent dressing materials. Okay, coming to the offloading. So offloading is making the patient walk. At the same time, the pressure should not be there inside the wound. So normally when the patient walks on the ulcer will never heal. That we all know, but making the patient, so lying in the bed will be a tough task. You can clean the wound, you can do the proper debridement, you can do the best dressing, but if you make the patient lie down, then only the ulcer will heal, but that's not going to be possible. No patient will listen to you. If at all they say, doctor, whole day I am on the bed, but they'll be walking here and there. They'll say they are inside the house, but they'll be roving here and there, and they'll make the ulcer worse. So our aim of offloading is to make the patient ambulant, at the same time reducing the pressure in the wound area. This is possible by increasing the surface area of contact, by redistributing the pressure in the other areas other than the ulcer area. So by reducing the peak plantar pressure, we can reduce the callosity, ulcer formation, and further infection formation. As we all know, in a normal shaped foot, the midfoot won't come in contact with the ground. So if you're able to support the midfoot, definitely the forefoot pressure can be relieved. So that's the basis of offloading. If the patient has a different foot deformity, they can have a choco foot, and according to the deformity, we have to devise the footwear. So offloading can be broadly divided into 3: global offloading, regional offloading, and local offloading. When the patient has a major infection, so bed rest, foot and elevation after surgical debridement, and proper metabolic control and wound dressing. So bed rest is mandatory. That's called global offloading. That's best. So then patients slowly they can move on the wheelchair, and slowly we can teach them to use the walker. With the help of walker and crutches, probably they can move around. And once the acute phase is over, the patient wound is in a healing phase, we can switch them over to regional offloading, like a posterior slab, removable cast walker, kind of things we can put that will give a proper offloading. And once the wound is healed, or in a grade 1A superficial ulceration, we can prescribe them a therapeutic footwear that gives the local offloading. And this is for maintenance and prevention, or even while treating minor ulcerations, we can use this. So local offloading, that includes the ortho-wedge footwear. Either it can be anterior ortho-wedge, posterior ortho-wedge, or molded insoles, or molded footwear. Either one can be prescribed for the patient. So here you can see the total contact cost and removable cost walker. And in this picture, you can see rigid rocker bottom footwear, molded footwear, and post slab on the other side. Post slab should be designed such a way that it should take up the heel pressure, and it should take advantage of utilizing the non-contact midfoot, so that the heel and forefoot pressure can be reduced. And not only the devices, we can do surgically also. So some of the cases, patient may have a fixed flexion deformity. They may have a mallet toe deformity, hammer toe deformity. That may not be possible with even the best of the best footwear. Even if the patient uses the footwear, but because of the fixed flexion deformity, they'll get too much pressure in the particular point. So simple tenotomy, closed needle flexor tenotomy can release the toe, and it can save the toe. So as you can see it, the ulcer will heal and it will never come back. And another case, he came with non-healing ulcer with multiple surgeries, local flap and muscle flap, everything he tried elsewhere. He came with a non-healing ulcer, and we noticed that there was an equinus deformity. So the deformity is corrected with the percutaneous tendon tendon lengthening, and the TCC was applied. So within 2-3 weeks, you can see the improvement, and within a month, it has healed. So this is how the offloading works. So proper dressing and offloading is very, very important for a diabetic wound management.